good deal of, oh, we're recording, okay. Got it, okay. Yeah, I think we have a pretty good, some idea of what's going on with long COVID, a good deal that we're starting to understand, and what I hope to convey here just as a kind of status update. As Susan said, I'm going to talk a little longer than most of the Stixrud Group lectures. Just I think a lot of the answers to your questions might be that we don't know yet, and also I don't have much personal experience with long COVID in terms of seeing them. So it'll be very boring if all I do is answer questions, but I'll definitely answer all the questions you have at the end and save time for that. So just to give you a little bit of a sense of what I'm going to go through, this is my agenda. So I'll talk a little bit about the background, the context of long COVID, lessons from history that we've learned, what long COVID is exactly, and what the symptoms seem to be. And then I'll focus on more of the neuropsychological impairment in long COVID. And then risk factors.
Carrot?
Oh, if maybe we could mute if we're just listening.
Okay. Could I ask everybody to please mute?
Do the risk factors for neuropsych impairment, and then I'll talk a little bit about future clinical assessment of long COVID and what I plan to do and other neuropsychologists plan to do. So first, I'll just take a look at the current state of the pandemic. We've had about 510 million cases of COVID worldwide, with about 6.5 million deaths. In the US, 81 million cases, with almost closing in on 1 million deaths. So needless to say, with these kinds of numbers, even if long COVID is extremely rare, say 1% of cases, we're talking about 1 million cases in this country. And chances are the prevalence is actually slightly higher than that. We can gather a bit about what to expect from COVID by looking at previous coronaviruses, including two recent ones, SARS and MERS, which you've heard of. SARS was an outbreak in 2002, 2003, and MERS was an outbreak in first reported in 2012. And we know that both SARS and MERS had an ability to cross the blood-brain barrier, or BBB, and affect the brain directly. So the BBB is the thing that prevents molecules from getting into the bloodstream, into the brain, from the bloodstream into the brain directly. And these viruses were able to cross over. You also had cytokine storms, or these excessive inflammatory responses as a factor in these previous coronaviruses. You had global ischemia, insufficient blood supply to the brain, and psychiatric symptoms in both the acute and recovery phases. About a third with PTSD, according to some studies, 15% with anxiety and depression. So a lot of stuff there. This paper published last year summarizes a bit of what was found in long SIRS and long MERS, which were things. The negative outcomes were mostly related to lung capacity, work capacity, fatigue, depression. And a lot of this data comes from healthcare workers who were on the front lines back then, just as they are today with COVID. We can also take lessons from conditions that we continue to assess and treat today, like acute respiratory distress syndrome, COPD. Both of those have long been known to cause cognitive changes, both acutely and chronically. We even sometimes see cognitive changes in pneumonia itself, or even severe asthma. Some have suggested that the cognitive difficulty that we're going to see in long COVID is similar to what we call chemo brain, or due to the role of inflammation in people who have had chemotherapy. So before we knew anything about what COVID would look like and what it would do, researchers were publishing papers on what they expected based on previous coronaviruses and other respiratory diseases and other conditions associated with cognitive change. And you can see, if you look back at the literature, like those papers I put up there from around March or April 2020, that was the thrust of what was being published. So while we do compare to similar diseases, COVID does seem to be unique in these severe outcomes, even when compared to flu or other respiratory tract illnesses. And this graph is from a paper by Takei and colleagues. I don't expect you to be able to read all these words. Don't worry about it. It's very small, but I just want to show you these red and blue lines. So this was a retrospective record review of over 236,000 patients diagnosed with COVID. And they looked at adverse outcomes like stroke, Parkinson's, dementia, muscle disease, depression, anxiety, psychosis, substance use, insomnia. So all these adverse outcomes that were first diagnosed after COVID. And you can see COVID here in red versus other respiratory diseases in blue. And the higher the line, the more frequent adverse outcomes were. So in this study, those with COVID were 1.32 times more likely than any other disease to get a first diagnosis of any one of these more severe outcomes. And if you look at data on flu, elsewhere in the same paper, those with COVID were almost 2 times more likely than those with just flu to get a first diagnosis of these conditions. Now, some caveats. First, a lot of these things are low prevalence to begin with. So we're talking about, for example, dementia being more of a risk after COVID, but still being found in only 2.6% of people over 65 in the study. And second, there was more substantial risk in those who had been hospitalized, and markedly more if they were in the ICU. So the take home here is that yes, COVID is similar to things that we've seen before, but it also seems to carry a little bit more risk for poor outcomes, especially if the illness is severe. So as time went on, we discovered more, of course, about what COVID would bring, unfortunately, and over the course of 2020 and into 2021, the real picture of long COVID emerged. And some of the first accounts that drew a lot of attention was from a British physician and actually an infectious disease specialist named Dr. Paul Garner, who actually himself was one of these first long haulers or someone suffering from long COVID. And he wrote a series of opinion pieces, almost like a blog in the British Medical Journal about his experience. He's fully recovered now, but it took him 11 months. And he wrote updates throughout that time. And I will say that one of the nice things about COVID is that all the articles are public domain. So studying COVID is much easier. It's purposeful, I think, to accelerate research and ideas. So Dr. Garner's series is available if you want to Google it, and all of these papers that I'm going to be mentioning today, you can find the full papers very easily. So the official CDC name is post-acute sequelae of SARS-CoV-2, or PASC, or PCNS is another name that you might see. So how common is this? It's a major question. It's really hard to say, and it depends on a few things. As you might expect, it really depends on time frame and symptom severity. So how far out post-infection are you talking? Does 2 months count as long COVID? Does 6 months count? How many symptoms are necessary to meet criteria? And who are you looking at? Those who are hospitalized, those with mild illness. So how are you calculating these prevalence figures? So far, it really depends on the study. And this is a 2021 review of multiple studies. So this is by Nasri and colleagues. They found that about 73% have at least one symptom at 60 days past symptom onset. So that's 2 months. In that Takei review I cited before, at 6 months, 57% had one or more long COVID symptoms. 80% of those had mild illness. And then Logue and colleagues found that 30% have, sorry, this is not COVID. 30% have persistent long COVID symptoms. Sorry, at 9 months. And that sample was 91% mild or asymptomatic. And you'll find a range of other prevalence figures in other studies, of course. So I'm going to be talking about long COVID in mild or asymptomatic cases, because that's what I'm most interested in. I think that's the bulk of what long COVID cases are going to be. But I want to make sure to reiterate that, of course, long COVID can cause severe neurological complications in the acute phase, including actual inflammation of the brain, stroke, Guillain-Barré syndrome, severe neuropsychiatric conditions like psychosis or delirium. So in these cases, particularly in the case of actual brain insult, like in stroke, of course, you're going to see the same cognitive impairments and psychological disturbance that you see in those conditions when they don't stem from COVID. So those types of presentations are really great referrals for neuropsych evaluation, but those are relatively rare outcomes. So outside of the actual severe complications of COVID, there are other possible mechanisms for how COVID affects the brain and what may lead to long COVID following even a milder course. So you've got, for example, viral neurotropism, which is actual invasion of the central nervous system by the virus. Hypoxia, which is lack of oxygen to the brain, and the hippocampus or the memory center is particularly vulnerable to that. You've got systemic inflammatory responses that disrupts the blood-brain barrier, hyperactivation of P2X7 receptors. Now we're kind of going beyond my area of expertise here, but that's another factor that can stimulate a neuroinflammatory process. And there's some speculation in terms of long-term effects that there's an immune response that's out of whack and lasts longer than it's supposed to. And I'm sure anyone paying some attention to long COVID has heard of that idea. So the short of it is we really don't fully understand yet, but it's some likely combination of these things. And in terms of the actual inflammation, COVID research has already shown inflammation in the heart muscles, even up to 3 months after a negative test. And we also see markers of persistent inflammation and immune response in COVID patients versus controls, up to even 15 months following infection. To go farther into some of the actual neurobiological findings, we've observed some of COVID's direct effects on the brain. One group showed inhibition of hippocampal neurogenesis, the generation of neurons in the hippocampus, the memory center, after COVID infection. And they also showed the loss of a substance called myelin, which is the substance in the brain that allows for rapid firing of neurons, that allows us to think quickly and reason quickly. And this was even found in those who had a mild infection. Other groups did some histopathology analyses through autopsy and showed that there was the presence of COVID RNA sequences in actual brain tissue, suggesting the presence of the disease there, though only in 20% of the patients, and those were people obviously who had died from COVID. And then we even have some evidence from brain imaging techniques like MRI and PET scans. In this MRI study, they took a look at people who had brain MRI before infection and then again at 5 months after infection. And they found that there were changes even in actual brain structure pre to post infection, particularly in areas that were associated with olfaction and smell or smell. As well as limbic areas that deal with memory and emotion. And they also had a control group who didn't show the same changes. And these changes may be reversible, they may not be, we just don't know yet. And research using PET scanning, which shows functional rather than structural changes in the brain, has shown that the frontal and the temporal lobes are less active, less functional in those with previous severe COVID illness. So overall, everything I've just told you through our knowledge of conditions similar to or overlapping with COVID, through our evidence of inflammatory processes, of immune responses, cellular level data, brain imaging findings, we have every reason to think that COVID does and can have direct effects on the brain, more likely in those with severe illness, but not excluding those with mild illness. And across the range of illness severity, these are some of the more common symptoms of long COVID. And I won't read this list to you, but just to point out first, you'll notice that these are a very wide range of symptoms from physical to cognitive to psychiatric, with the most common symptom being fatigue, with estimates showing about 85% of people reporting it when people are recovering from COVID. How long that lasts in each person is more difficult to say. Of course, you're going to be fatigued if you've gotten COVID. How long does it last? And in terms of cognitive symptoms, you might have heard of brain fog. This is the term that you might hear come up most to describe the cognitive changes seen in long COVID. And you'll hear the same term in conditions like concussion or post-concussive syndrome, fibromyalgia, multiple sclerosis. And it's pretty much how it sounds, mostly meant to describe problems with attention and speed of information processing, memory, word finding difficulty, executive dysfunction like trouble with planning or organization. And so it's one thing to delineate the typical symptoms of long COVID, but it's another to look at the actual functional outcomes of long COVID and implications for real world impairment and societal costs. And I think we may be just beginning to understand this. But one study by Huang and colleagues looked at 1,276 COVID survivors in China, mean age of 59. And they found that 68% had at least one symptom after 6 months, 49% after 12 months, but also that 88% of survivors had returned to their original job at 12 months. Of the 12% who didn't return to work, the most common reasons were decreased physical function, unwillingness to return for whatever reason, or having been let go, and there were some others. And critical illness was associated with worse functional outcomes. So you've still got about 4% here of survivors who didn't return to work because of persistent physical illness at 1 year post-infection, which is not negligible when you think of the broader societal impact. Again, that being said, and I'm going to keep saying this caveat, this research was done with patients who are among the first to become infected with COVID, no vaccinations, more severe illness was associated with the worst outcomes. So again, we have to take this with some caution that the numbers may not hold up for our present day situation. So that's sort of a broad overview for what we're dealing with in terms of COVID infection, potential long-term effects. I'm a neuropsychologist. I'm mostly interested in how long COVID relates to cognitive and emotional psychiatric impairment. So just to be clear about what my area of expertise is, it's cognitive functioning. And what I mean by that are things like attention and memory and reasoning and planning, but it's also psychological, it's emotional, psychiatric, and how the cognitive functioning might be interacting with emotional difficulties. And then we as neuropsychologists also have some knowledge of the cognitive and emotional effects of things like acute lung disease or kidney and liver disease and autoimmune disease. So some of the conditions that can be associated with COVID. So I mentioned prevalence of long COVID in general. What about prevalence of specifically cognitive symptoms in long COVID? And again, I'll cite that paper by Nasri, who showed that 25% of patients reported cognitive difficulty. A more recent study showed that at 12 months, prevalence was about 12 to 13%, with those who had more severe illness having greater likelihood of cognitive impairment. And in this study, cognitive impairment was actually measured in the clinic. So you had patients in clinics getting tested and coming up with measurable cognitive difficulty. And then another recent study done by survey of about 150 survivors showed that 67% of respondents reported a brain fog. And this study was limited by possible selection bias because it only had a 48% response rate. So in other words, there may have been something about respondents that makes them different from non-respondents, and then you're looking at only a skewed subsample of COVID survivors. So what I'd like to do is take you through some examples of studies where the researchers actually took long COVID patients, sat them down for neuropsych testing, and looked at what they found. So it's one thing to survey people and ask them, how's your cognitive functioning? It's quite a different thing to actually measure it clinically. And I've tried to pick out studies that did a really good job with this, those that were the most recent, published in reasonably well-regarded journals. So for example, this one by Cicchetti and colleagues was published in the Journal of Neurology this year. So like so much of the research out there, this was done on patients who had COVID in the spring of 2020. And they followed them longitudinally, did cognitive assessments at 2 months after infection and at 10 months after infection. So you can see here at 2 months, 53% of patients showed impairment in at least one cognitive domain, particularly in executive functioning here in red, and 25% had impairment in multiple domains. After 10 months, you've still got 36% of patients showing impairment in at least one domain, with 21% in multiple domains. This study by a group in Barcelona looked at 58 patients, 6 months post-ICU, 41 days in the hospital on average, 26 days in the ICU. So we're looking at a sample with more severe illness now. 53% of these patients scored below 26 of 30 on the MoCA, which is kind of our gold standard cognitive screening test. And that threshold of 26 may seem high, but it's the cutoff for detecting a noteworthy amount of cognitive decline. So the vast majority of people scored perfect or close to perfect on that test. And then they gave a more comprehensive battery, and low scores followed the familiar pattern of trouble with speed and executive functioning and memory. This one by Becker and colleagues done at Mount Sinai in New York, published in JAMA. It's in preview letter form. They're working on the full paper, but they did neuropsych evaluations on 740 patients who were 7 months post-infection. Mean age 49. Sample was reasonably diverse in terms of race and ethnicity, which is a nice thing you get from Mount Sinai. And they found a modest level of cognitive impairment across domains in a similar pattern to what others have found. So this does suggest some degree of cognitive difficulty even months after COVID infection. Again, more caveat, this sample may be biased because they're patients who followed up at Mount Sinai for health concerns and then underwent clinical neuropsych evaluation. People who didn't follow up weren't observed. So these percentages you see here are likely to be an overestimate, most likely. Some studies suggest that cognitive impairment in long COVID is actually pretty mild, if it exists at all. This study by Krishnan and colleagues at Cleveland Clinic, published in one of our best journals, the Archives of Clinical Neuropsychology. And these patients were seen for neuropsych evaluations between September 2020 and April 2021, mean age 45. This was a sort of narrow sample of 20 patients, and 85% of them had some medical or mental health diagnosis prior to infection. And they were given a very comprehensive neuropsych evaluation around 5 to 6 months after their diagnosis. And findings actually showed a relatively mild neuropsych difficulties in attention and speed and executive function, as brain fog type stuff. The vast majority were actually cognitively intact. And in this one, severe illness wasn't associated with worse outcome. So the authors suggest in this paper that this could be due to things like mood and sleep issues and fatigue, which was actually seen in most of the sample rather than COVID per se. In terms of psychological effects, specifically in long COVID, the Cicchetti article I showed you before also looked at this and showed at 2 months, 28% of patients have either depression or PTSD symptoms or both. And at 10 months, 33% show these emotional difficulties, 18% showing PTSD features. So slight increase in PTSD type symptoms in those with both depression and PTSD symptoms from 2 months to 10 months follow-up. And then this article by Whiteside and colleagues published this year in January, again, one of our best journals, the Clinical Neuropsychologists. This group is in the University of Minnesota and the Mayo Clinic in Minnesota. So they looked at psychological and emotional functioning in 43 COVID survivors, 6 months after infection. They gave them one of our gold standard measures of emotional functioning, the PAI, or Personality Assessment Inventory. And from those results, most prominently, they saw an unhealthy preoccupation or anxiety about health concerns, as well as some depression and traumatic stress. And it's also important to note here that half of the sample had pre-existing depression, more than a quarter had anxiety or PTSD beforehand. So again, we have a bit of a selection bias going on here where the people who are involved in studies on long COVID are the ones most likely to be motivated to come in for these lengthy neuropsych evaluations. And interestingly, there were no differences seen in the emotional scores between patients who are hospitalized versus non-hospitalized, which means that a physiological or neurological cause is less likely than an environmental or psychosocial cause. Because shouldn't it be that those with worse disease would be more depressed or anxious or traumatized? It doesn't seem to be dose dependent here, where greater severity leads to worse psychological outcomes. And this is similar to what we see in traumatic brain injury and concussion. The authors also note the possibility that people are being sensitized by media or other socio-environmental factors to become highly attuned to their bodily symptoms and to attribute even very vague, non-specific symptoms to COVID, like brain fog. So this is not to diminish concerns about the direct effects of COVID on the brain. We have, like I said, plenty of evidence that there is one or can be one. We also have increasing evidence that there's also a psychosocial effect here. You'll remember this graph, Takei and colleagues. It's worth mentioning that psychiatric disorders seen here in this part of it were associated with COVID infection and not associated with illness severity. So again, what does that mean? Well, if direct biological change alone was causing depression and anxiety, you would see a dose-dependent response with worse illness being associated with worse depression and anxiety. That's not what we see. So this is consistent with the Whiteside study I just showed you, suggesting that the psychological effect of having had COVID may be more important than actual direct biological effects when it comes to the psychological or psychiatric aspects of long COVID. So to kind of hammer this home, are long COVID symptoms always actually attributable to COVID itself? The answer actually seems to be not always. And this paper by Mata and colleagues is maybe my favorite that I came across, published in JAMA. And it really underscores the sort of challenges that COVID researchers are up against here, the challenges that clinicians will face. So they examined the association of self-reported infection. So here I had COVID, I didn't have COVID, and antibody testing. And they looked at that and how those related to physical symptoms. So the antibody data, as you may know, can actually detect with a pretty high degree of certainty whether someone has had COVID in the past or not. So they gave the antibody test to an incredible number of people, about 27,000 people. These people got their antibody test results, and then they were asked if they had COVID or not in the past. So participants were aware of their blood test results when they reported that they had it or not. Okay, so you think, fine, so these cells should have all the numbers here, right? So people with positive antibodies should say I had COVID. People with negative antibodies should say I didn't have COVID, but that's not the case. We see some numbers here in these cells. People who got their positive antibody and still say I don't think I had COVID. People got negative antibody test results and say I still think I had COVID. So we can kind of disentangle some of these beliefs from the actual experience of having had COVID. And they asked about these persistent physical symptoms. And I won't list them all here. There's 18 of them, but sleep, joint pain, sore muscles, poor attention, sensory symptoms, stomach pain, palpitations, dizziness, things like that. So an actual positive test was associated with greater likelihood of 10 of the 18 symptoms. Okay, that makes sense. But they found that belief that one had COVID was associated with a greater likelihood of having 15 of the 18 symptoms, more of those symptoms. And when controlling for the belief that one had COVID, an actual positive test was only associated with anosmia or loss of smell. So there appears to be a possibly very large psychological factor here. The belief of having had COVID can change someone's perception of normal, everyday bodily experiences. Or alternatively, having persistent symptoms like these makes you think you had COVID and maybe even causes behavior change like reducing physical activity, which will then maybe perpetuate symptoms. So I thought that was really interesting. Let's go back to this Costas Carrera study from Barcelona I mentioned. Well, this group not only measured actual cognitive impairment, but also concern about cognitive impairment. And they found that the two were not related. So those who were the most concerned about cognitive performance were not the ones who did more poorly. Actually, concern about cognitive performance was more strongly correlated with scores on measures of anxiety. And I'll also go back to this Krishnan study where only minimal cognitive impairment was actually seen. How many of the participants in the study do you think reported having memory or concentration or brain fog issues? Like how many endorsed noticing these things? A lot. So the vast majority of subjects reported these things. Whereas when they did the actual testing, there really wasn't much there. So again, we have to be careful to understand the differences between self-reported cognitive difficulties and actual measurable cognitive deficits, because we as humans are actually not that good at determining how good or bad our thinking abilities are without testing. And that's always been known for decades. It's not COVID specific, but anxiety about COVID is through the roof, and about long COVID is through the roof. So it's conducive to these sorts of reports, similar to what we see in concussion and dementia, also to anxiety provoking conditions. So I'm keeping an eye on the time. I just want to go through some of the things that carry a higher risk of developing neuropsych impairment after COVID. I'll sound like a broken record here, but the severity of illness, of course, is an important risk factor. Many of these studies have found this. There are different ways to measure this. The most inclusive way is simply whether somebody went to the ER or was hospitalized, but there's also ventilator or ICU stay, things like that. Higher body mass index, also a predisposing risk factor, probably mediated by illness severity. Regardless of severity, some research shows that loss of taste or smell itself is associated with not only cognitive dysfunction, but also headaches, presumably because it suggests some actual brain involvement, and pre-existing conditions, both medical and, but also a history of depression and anxiety. I had a slide about cognitive reserve, but I think I'll skip through that. Basically, cognitive reserve, or the idea that we build up brain throughout our lives with enriched experiences can actually protect us against long COVID here. And I can answer questions about that if you have that. More important, how well do the vaccines protect against long COVID? That's just such a huge question. And obviously we're just starting to figure that out. And in fact, this update was just published in the Times last week. The main message is that there's some evidence that vaccines protect against long COVID, but results are mixed. They cite this UK Health Security Agency study, but basically to summarize, 6 of 8 studies showed that vaccination before infection reduced likelihood of long COVID as early as 4 weeks or as late as 6 months. Most studies looking at vaccination after infection showed improvement in symptoms after vaccination. A small proportion of cases reported worsening of symptoms, but the majority showed that vaccine can improve long COVID symptoms. And some studies looked only at unvaccinated people who developed long COVID, compared those who then got the vaccine versus those who decided to remain unvaccinated. And those that got the vaccine post-infection were less likely to report long COVID symptoms after that, and much less likely if they got the vaccine very soon after infection. And other studies show anywhere from 13 to 90% reduced risk of long COVID with vaccination. So it's just a very wide range. But the overall message here is that vaccines seem to reduce, but don't eliminate risk of long COVID. 5 minutes, so because I wanted to stop at 7:15, but here are some of the problems with research. What's the role of vaccination? What variant are we talking about? What time intervals are we talking about? Looking at making sure we're measuring cognitive impairment versus reports of cognitive impairment, and all of these issues with selection bias and who we're studying, basically. So I don't do the research again, so I'm happy to leave that to the researchers. But my goal is to take what they find and translate it into clinical assessment. So I just like to take you through how I and other neuropsychologists plan to address long COVID in the clinical setting. That's my last point here. So as I see it, there will be two types of presentations of long COVID, and you probably gathered that from what I've been saying. The first type here in pink may look something like someone with a medical history, like vascular disease, diabetes. They'll have had maybe severe illness, maybe they're hospitalized or in the ICU for some time, and they're probably more likely to be socioeconomically disadvantaged. We have to remember that. For these people, it'll be important to document the nature of their impairment, how functionally impaired it makes them in their day-to-day life, and actually look possibly towards work-related accommodations or even possible disability. The second type, here in blue, will have a more unremarkable medical history, but they may have a positive psychiatric history, so a history of depression, anxiety, trauma, or a mild or asymptomatic course, persisting symptoms that include fatigue or brain fog. And so for these people, the goal will be different. It'll be important to explore their psychiatric history, the possibility that there's something else causing their fatigue or brain fog rather than the actual direct effects of COVID infection, and to give them education about how to manage or treat these other factors. And I'm not saying that they wouldn't have had acute COVID effects while they were sick, but the idea is that over time, something else takes up the mantle of symptoms that are not specific to COVID. And if post-concussive syndrome is any guide, which for me it is, I'm almost positive that there will be people with long COVID symptoms out there, even years after their infection, that will be attributing those symptoms to COVID infection without much consideration of other potential factors that are contributing or perpetuating it. There is a NeuroCOVID international task force that's involved in making recommendations, not only for harmonizing research, but also for clinical work. And some of the guidelines include just a run-of-the-mill 2 to 4 hour comprehensive neuropsych evaluation, exploring the course of COVID and severity, exploring psychiatric history, even including olfaction or taste testing in the neuropsych testing, which would be interesting. Activities of daily living, of course, understanding functional capacity. Of course, as with most patients, we want to give performance validity testing to make sure people are trying their hardest and are on the level. And then looking at emotional functioning and what their emotional status is. And we have health perception questionnaires that really get at how people are perceiving their own health and how it might relate to things like anxiety and depression. So the last thing I kind of want to say is just for doctors out there who are wondering when to make a referral, or for people out there with long COVID who are wondering when to seek help, noticing persistent symptoms following COVID infection after about 3 months or longer. And people will probably say that they have this brain fog. They may use that term, but otherwise poor concentration, memory lapses, Fatigue, of course, is going to be a very common symptom, and also depression and anxiety and post-traumatic stress. So these are some of the signs of that. So just to kind of wrap up and summarize right on the dot, we can learn a lot about what to expect from long COVID from previous coronaviruses, conditions similar to COVID. Long COVID includes a range of symptoms, most commonly fatigue and brain fog, probably caused by systemic inflammation or immune response, or by direct brain involvement in more severe cases. And it's going to occur in a relatively small but significant number of patients. The neuropsych impairment is also going to be seen in a relatively small percentage of patients, more likely in those with severe illness, not excluding those with mild or asymptomatic illness. And psychological aspects of long COVID should be explored as well. Risk factors for neuropsych impairment include not only medical variables like severe illness and higher BMI, but also pre-existing psychiatric disorders. And finally, neuropsychologists are well positioned to help assess patients' concerns, to make recommendations for the future in a holistic way, taking into account the whole person. So doctors should be aware that, yes, there are going to be patients who have persisting effects of COVID, but there are also going to be many patients who attribute their current symptoms to COVID that occurred not only 6 months ago, but maybe years earlier. And some percentage of those patients, I think, will be misattributing those symptoms, and it'll take some good assessment to figure that out. So with that, I will wrap up and take your questions and stop rambling.
It's fantastic, Jesse.
Okay, thank you.
Let's see what we have in the way of
yes.
questions in the chat. So this I think you kind of covered, but you were saying when you're talking about the percentages in the various studies of people with and without symptoms, that's all looking at, is it, actually, I'm a little unclear when this was sent. Are we looking at a full population and a population of people who had COVID, or a population of people who complained of long COVID?
Yeah, most of these studies were of people who had COVID. I think pretty much every study I saw was a survey of people with long COVID. Well, I shouldn't say, actually, the ones that have the full pies and everything were a survey of people who had COVID. I shouldn't say long COVID, and how much were persisting. Yeah.
Okay. Someone asks, does long COVID trigger autoimmune responses? Is that what perpetuates long-term inflammation?
I think that is one of the ideas. I think there are, I think as I mentioned on one of my slides, there is some evidence that there is a persisting immune response that's just not right and kind of out of whack, and it persists. So
this is not actually a question about your talk per se, but are we going to have a link to the presentation afterwards? And we'll be talking about getting it up on our website.
Sure.
Is there any sense of changes in the rate of long COVID development as the virus continues to mutate? Has that been done yet?
So what we're looking at what most of the studies are looking at is long alpha. So, I almost wanted to put a timeline of how long these studies take. So, the studies that are coming out now, or, in 2021, are really looking at people who were first infected in the spring of 2020. That's just something I kept seeing over and over again. We're just starting to now look at long delta, and we're going to see if those numbers change. Delta was, not necessarily milder. I'm really curious what's going to happen with long Omicron, and that will have to wait a year or so. But I hope that some of these prevalence numbers come down. We don't see as much of it from mild illness.
Also, whether some of the sources of data are falling off. I've been participating myself in the Zoe study through
Oh,
King's College
uh-huh.
and UMass, or no, Mass General, and
Yeah,
they had this enormous number of people, 100,000 people reporting
yeah.
daily. At the
Wow.
beginning of COVID, do you have any symptoms? Have you been tested? Now,
Yeah.
now I report like about every 3 weeks. I think, oh, I should get on there, but
Right.
it's not that doesn't provide
Ah,
any useful data.
right, right. Yeah,
Um,
it's,
because they were the ones who came up with a lot of the first symptoms that people weren't so sure about, things like the loss of smell and taste, which is
right.
critical.
Okay.
So
Yeah,
I don't know. Anyway,
definitely.
let's see. Given the hippocampal neurogenesis and myelin loss, would we see poor episodic memory and greater anosognosia? Sorry.
In greater anosognosia.
Yeah, thank you.
Possibly. I didn't see anything about anosognosia specifically in these results. You know, they stick to the, you know, boilerplate attention, memory, things like that. I think some of these findings do suggest some episodic memory difficulties, including I think the Becker study from Mount Sinai. But yeah, that is what you expect, and hopefully that the hippocampal effects are going to be relatively rare, uh, and seen mostly in people with severe illness.
Another comment, I wonder how this compares to the numbers in the general population, COVID versus the general population, given that as so many people have experienced mental health challenges because of other aspects of life changes and stress during the
Yeah,
first year of the pandemic.
yeah, that's a great question. I didn't see anything teasing that apart, but yes, there were increases obviously in depression and anxiety in general, and some of the things that we're seeing in long COVID could simply be, you know, those changes in your environment and other things. So I think that's a great question that we need to answer.
Yeah, I think definitely.
Yeah.
Um, a more specific one. Somebody writes, I have what my doctor says is possible long COVID. One of my
Mm.
symptoms post COVID has been the feeling of static electricity on my brain. It's
Mm,
not the same feeling as brain fog. Any
right.
idea if there's an actual name for this? My doctor says possibly brain zaps, but I don't
Right.
think that feeling it quite fits it either.
Yeah. Yeah. I've heard people reporting that kind of symptom before. I haven't heard of brain zaps per se. Um, but I don't know. That's something to keep following up on. I didn't see anything in all of my lit review that suggested that kind of symptom. So I would just keep up on that with your neurologist. Is it? I don't know if it's neurologist or primary care, but if it is primary care, I would suggest seeing a neurologist. Absolutely.
Other than avoiding getting COVID, is there anything recommended to not develop long COVID?
Well, I mean, we saw some of the risk factors, right? So reducing BMI, you know, because COVID's going to be around for a while, maybe forever. So just getting in shape would go a long way, I think. Getting vaccinated, you know, most people are, but some people are not. So getting vaccinated seems to help. And if you're not vaccinated, getting vaccinated after you get infected. Um, but you know, other than that, I don't think we know enough other than that to reduce symptoms, just to make sure as much as you can that you have a mild course. That's really the take home.
Another one asks, does the severity of long COVID symptoms relate to the length of recovery? The more severe symptoms predict longer recovery. His wife has long COVID and has had a
Mm,
series of UTIs, which have recently been suggested as a symptom of long COVID. And is this
mm,
showing up in the research?
mhm. Yeah, well, if what I'm understanding right, yes, a greater severity of illness is gives you a higher risk of long COVID. So, and I think, was that the answer to the question? Did I answer that?
And then somebody had raised a hand. Do you want to just ask directly?
Yes. Hi, Dr. Brand. Thank you so
Hi.
much for this.
Sure.
This actually popped in my head as Dr. Hammond was reading Sharon's question about not getting long COVID. And I know earlier you were kind of mentioning the importance of psychosocial aspect, that, that there's a role that plays there. And I kind of was wondering if you, in your research, which sounds like you've done quite a bit of it, if there's anything that talk about protective factors or maybe like support or help during when someone is sick. Does that kind of mediate a little bit of those symptoms? Does it help?
Oh, I would be sure of that. I actually didn't see that per se in the research, but I would imagine, if a patient came into my office and they had mild illness and they had mild COVID, long COVID, I would suggest, if they had depression and anxiety, I would certainly suggest therapy, and especially a therapist who has experience in treating people with medical issues and chronic medical issues. I think that could probably go a long way for the psychosocial variables in effect. And possibly as well as psychiatric medications if the depression or anxiety were to be severe enough. So
thank you.
Just a couple more. Somebody saying that the comparison with post-concussive syndrome in terms of measurement and the unpredictability of long-term inflammation of the CNS was really interesting.
Mm-hmm.
And then somebody asked, have any studies been done about children and long COVID? Would the symptoms look the same?
Yes, that's a good question. I did not come across those studies. It's true. I'm so adult focused. I only see adults. So I hope I didn't subconsciously drown those out, but I didn't see anything in pediatrics. I'm sure they're out there. And again, if you're interested in that, all of these papers are so available. They're public domain. So if you're interested in looking into that, I would encourage it. I didn't come across it myself.
Somebody asked, will there be follow-up sessions as the research continues? And I would imagine, sure. Yes.
I'm gonna keep up on the literature. So
and we love at the Stixrud Group, we love giving all of our doctors a chance. I go around walking the halls saying, "Come on, do a webinar. What do you want to talk about? You can talk about anything." So
great. Yes.
We'll be back.
Good. Yes. Right.
Did you find any discussion around inflammation of the basal ganglia? Somebody had heard of some psychiatric issues being seen that could be related to that mechanism and similar to PANS or PANDAS.
Yeah, I didn't see anything like that specifically, but that's interesting. There's so much out there just coming out every day. So it's kind of hard to keep up, which is exactly why I should do another one maybe same time next year.
I think so. Absolutely. Do we have anything else? This is okay. Thank you all for coming.
Thank you all so much.
This is fun for us and nice to get research and information out there to people.
Thank you all for coming.
And on your screen is Jesse's contact information, which is also the contact information for everybody at the Stixrud Group. So you can find him. You can, if you have a child who you're concerned about, we do a lot of evaluation of children as well as adults. If we cover the age span. So
thank you. Really everyone. Excellent. Thank you so much, Jesse.
Thanks,
this was amazing.
Great. Thank you.
Somebody just asked, what's the time frame for getting your kids in for testing? Realistically, in the fall. We are largely booked in the summer, although we do get, because people are booking way out, we do get cancellations or rescheduling as they discover that the week that they scheduled with us was the week of horseback riding camp and they can't possibly miss that. So the scheduling is somewhat fluid, particularly for kids. But if somebody is interested in getting an evaluation, I would encourage you to call as soon as you can. We have a system where we then get you hooked up with some client care manager who does a half-hour to 45-minute background interview and then determines who would be a good fit for you and schedules the evaluation. And again, the more flexible you are about time, the greater the chance of actually getting in during the summer. So thank you, everyone, and have a great evening. Thank you, Jesse. This was
Thank
lovely.
you all. Thank you.
Okay. And I'm gonna stop recording.